So YouTube completely redid their live streaming setup on YouTube. It took me a while to figure out how to use it correctly. They did like a bunch of. I mean, the new dashboard is really nice. It definitely is. It just it took me some time to figure out how to go live. I was supposed to go live a little earlier today, but I couldn't really figure out the layout, or like I was being a little lazy about it too. But all good now. I read about it. I checked it out. Made sure I understood how it all worked. And here we are. So NBME 22, I'm going to wrap it up this weekend, finish it, and then get back to first aid. Finish up reproductive and respiratory so we can be done with first aid for step 1. I've got two more videos I want to do about just step 1 in general, like the study patterns and stuff like that. Something that I've been trying to put together for a while. And then I'm going to be, after New Year's, I'm going to be focusing solely on CK and CS materials, something that a lot of people who were following me all along, who are done with their step 1, they've all been requesting it. So it's definitely something that I'm putting together in the back, making a good outline out for you guys. So that should be coming after New Year's for sure. For now, let's wrap this up. So here we are, NBME 22. We're now at question 141, so just 59 more questions after this. 45-year-old man with chronic pancreatitis caused by alcohol use disorder comes to the office because of a 3-month history of diarrhea. Physical exam shows no abnormalities. Examination of a stool specimen shows a markedly decreased amount of fecal elastase. Which of the following medications is most appropriate for this patient's diarrhea? Now, a couple people were actually pretty inclined to go with loperamide because loperamide is a pretty high yield medication on NBME. They really like asking you questions about loperamide because it's an opioid that you can actually take for diarrhea. Just like all opioids, this one also causes constipation, and that just works out because it's going to be perfect for diarrhea, right? So clinically used diarrhea, adverse effects, constipation, just like any other opioid. Right? Loperamide and diphenoxylate are also discussed later on in neuro. And the good thing about loperamide is that it has a very poor CNS penetration, so you're never going to hear about someone getting addicted to it or stuff like that. And this would be great for someone who's going through diarrhea in general, but our patient doesn't just have diarrhea, right? This patient has an issue of chronic pancreatitis, and there's no fecal elastase. So what it looks like is that this patient's 3-month history of diarrhea is simply due to pancreatic insufficiency. And they got really creative with it. The correct answer was just give the patient pancreatic enzymes, and they'll be able to digest stuff well, and then they'll be okay. Instead, they put this answer choice of pancrelipase, right? Which is, I put it right here, in fancy pants NBME world, pancrelipase just means pancreatic enzymes. So a low amount of fecal elastase is common in pancreatic insufficiency. Use pancrelipase, which is a combo of lipase, protease, and amylase, to remove the malabsorption. That's the kind of diarrhea this patient has. This patient has diarrhea due to malabsorption. Right? So loperamide, well, if you gave this patient loperamide, it wouldn't necessarily fix the diarrhea because the malabsorption would still be there. So, eventually continuous use of loperamide might cause constipation in the patient in general, but they would still have the malabsorption issue, right? So what you would then note, if the patient started taking loperamide long term, you would note that the patient was just, it looked like they're not eating well, and they're going to start having vitamin deficiencies and stuff like that. So loperamide would be the wrong answer for that question. This one, 48-year-old man with renal artery stenosis, right? NBME's favorite topic, undergoes stent placement. Femoral access is used to place the stent. After entrance into the aorta, the guide wire should be advanced superiorly, just beyond which of the following structures to approach the right renal artery in this patient. So the question was really just about knowing the anatomy of the branches of the aorta. So I put that here. And you look at the answer choices: celiac, internal iliac artery, superior mesenteric artery, and testicular artery. So they're entering, right? They're entering from the femoral area, and they're going to advance just above what? Right, that's the question. You have to go just superiorly, just beyond which of the following structures to enter the right renal artery. So basically the question is asking what comes right before the renal artery, going from down to up, and that would be your testicular artery, right? As you go from down to upwards, the only artery you get first is the testicular, and then you have the renal arteries. That's all they were really asking you. And of course, you should know, right? Internal iliac is all the way down here. That's not even going to be utilized, right? Because they're coming from the femoral. They're going to be using the external, go up to here. So they're not even going to use the internal iliac. But that's all the way down here. So there's definitely, after internal iliac is where you have testicular, so that wouldn't be right. Celiac and supramesenteric are way above, so they wouldn't be correct answers. Okay, that would not make sense. It is very important to, even in reproductive, to remember that the gonads originate in the abdominal area. So when you see testicular artery, you need to think, okay, that would be very close to the renal artery, and that was the correct answer. Celiac, trunk, supramesenteric, not going to be the correct answer choices. So those were really just there to confuse you, but you should know the anatomy of those guys as well. Very important from GIT. Let's take a look at it real quick. Alright, so right here. Okay. Right, so you have your celiac, and then you keep going down, you get your, right, the whole celiac thing for the stomach, liver, spleen, and pancreas. Then you have your superior and inferior mesenterics. Where the inferior mesenteric would be down here, the superior would be about at the same level of the kidneys, and in between them, there's still the testicular artery, right? So inferior mesenteric artery was one of the answer choices, and it is here. It's here, but after the inferior, you get testicular, then you get renal, and they wanted to know what comes right before the renal artery. So right before is testicular. Okay. 13-year-old boy is brought to the physician for a well-child exam. He says that he's teased by his peers for having breasts like a girl. He has no history of medical illness. He takes no medications. He's at the 50th percentile for height, 60th for weight, and 60th percentile for BMI. Physical exam shows a small, soft mound of tissue bilaterally beneath the areola. His genital development is Tanner stage 3. Which of the following is the most appropriate next step in the management? Now, NBME really likes questions like this because, it's pretty intimidating, especially if you don't know Tanner stages like the back of your hand. But the fact of the matter is, and I said this before too, this sentence where they're giving you the percentiles and stuff, right? These percentiles are very irrelevant, unless the percentile is super bad, like he's in the 20th percentile for height and 15th percentile for weight, something like that. Other than that, everyone's different, so everyone develops differently, and everyone's body is different. So being in the 50th and 60th is not that bad, right? That's okay. Being below the 30th or below the 40th at least, right? You can pick a cutoff point below the 40th. Below the 40th percentile is where you need to be concerned, right? So if they gave you stuff like this sentence basically told you, okay, he's all right, he's doing fine. Maybe he's just growing a little different from others, but he's doing just fine. There's really nothing wrong with him. And also, if he did have a breast issue, right, if he did have something wrong with his breast, it wouldn't necessarily be bilateral, right? Most likely, if he had maybe for some reason some kind of cancer in the breast or some kind of lymphadenopathy or anything like that, usually it would be unilateral. And a bilateral problem with the breast could be due to prolactin or something, but that would also have other symptoms. They really didn't give you anything for you to worry about. Kids develop in different ways. The answer was just reassurance. The other answer choices, measuring growth hormone, LH, or testosterone, or doing a mammography, would all just be really unnecessary, very unnecessary. Right? You really don't want to order things that are not needed, right? That's going to be expensive stuff that either they or their insurance is going to have to pay for. And there's really no demanding factor for you to go ahead and investigate any of these other things. If his growth was really bad, right? A lot of people fell for growth hormone because they thought this is bad. That's not. Really bad would be like under 40th. If his height, weight, BMI were all really, really low, below 40, then you could possibly, think of maybe he's not growing well enough. Maybe he does have some kind of central hormone release issue, but there's really nothing like that in this guy. Okay, 62-year-old man comes to the physician office for excision of an invasive squamous cell carcinoma on the lower lip. The physician has explained the reasons for the procedure the technique to be used, the possible complications, and the identity of the physician who will be performing the procedure. Which of the following additional information is required for informed consent? And the only thing they didn't list out is alternative treatments, right? Remember, alternative treatments also means that they can choose to have no treatment. If they want to keep their squamous cell carcinoma and not do anything about it, that's completely up to them, right? 62-year-old man, he might not want to do anything about it. If it kills him, he might be okay with it. You have to let him be. Knowing informed consent is very critical because that's a very realistic thing. Once you start residency, oftentimes someone might ask you to go do the informed consent procedure. You cannot do the informed consent procedure, and you would tell your attending, it'd be better if you went. It'd be better if you attended with me. If you did something, don't be like, okay, I'll go do it. You can't, because you probably don't know the procedure that well. If you don't know the procedure very, very well, if you don't know everything about the procedure from start to end, and if you've never witnessed it being done, you can't go ask for informed consent about it, because how are you going to inform somebody, right? The whole concept of informed consent is you inform somebody, they give you consent. You can't inform someone if you don't know everything about the procedure. Okay, and that's another type of question that's often on NBME, and both types of questions can be on step 1. So it's very important for you to know everything about the procedure before going in to ask for informed consent. And part of informed consent is alternative treatment. Now, this is discussed in first aid, I think in the ethics place, yeah. Right, there's an entire thing, informed consent. Okay, disclosure, understanding, capacity, and voluntariness are another very important part of this. Also understand that patients must also know that they can revoke consent at any time, even orally. So if they signed a document giving consent, and then right before the surgery, if they want to say, okay, you know what, I don't want to get the surgery done, they have every right to do so. And as a doctor, you have no reason to stop them from asking for this kind of thing. And you just go ahead and say, okay, we'll cancel the surgery. Regardless of whatever, you're going to get paid for whatever is supposed to happen. And the main thing is to do whatever the patient wants. Okay, so very important to understand that. Very important to understand the wipe aspect, right? All the exceptions for informed consent, because these are all things that are technical and very realistic, part of your job, and you can definitely get questions on it. 35-year-old man comes to the physician because of an itchy rash on his hands, waist, and feet for 2 days. He says that his wife and 3 teenage children are beginning to develop the same symptoms. He says we live near a wooded area and love to hike in the woods. Physical exam shows 2 mm erythematous papules in the finger webs, wrists, umbilicus, genital area, and toes. Scrapings of the lesions show mites and eggs. Which of the following is the most appropriate next step by the physician? This is the second question on the same exact thing in this same exact NBME. Ectoparasites, right? The most appropriate next step is to just treat the patients, to use permethrin for their scabies. There was another question on scabies in this same NBME in one of the previous videos I've already posted. Scabies is very contagious via skin, contact, or fomites, so treat close contacts too. And as you could tell, everyone's got it in the family. Choice B, instruct the patient to use DEET, bug spray while hiking, will be the preventative advice you would give them, but the most appropriate next step here was to fix the issue first, right? So you give them the permethrin and get rid of it, treat them first, then you advise them for preventative care. Right? And the other question that this same NBME had about scabies was about what you would ask a patient when they come in, showing you that there was an actual picture of the guy's hand, and they were showing you the burrows and whatnot that the scabies is making in their hand. And the question was just like saying, what would you ask the patient? And you would ask the patient if anyone else in the family has it, right? And they would tell you yes, because scabies is very, very easily given from, through contact, given from one family to the other, one family member to the other. So if he said no, then no one else in the family has it, then it most likely isn't scabies, and at that point you would treat it with something else, and you would investigate what's happening. This one, 45-year-old man with end-stage renal failure is brought to the emergency department by his mother because of his feelings of depression and apathy for 2 weeks. He has been receiving dialysis 3 times weekly for 5 years, but he has missed the last 3 sessions because I've been too depressed to do anything since my wife left me 3 weeks ago. Bilateral crackles are heard on auscultation of the chest. Mental status exam shows confusion. Serum studies are most likely to show a decrease in which of the following concentrations. So the bilateral crackles right? That's telling you something's wrong with the lungs, and it's mainly because something's wrong with the heart, right? He's probably developing left heart failure, which is causing blood to back up into the lungs. So that's one thing. Mental status being confused is a sign of, usually a sign of hyperammonemia, because he does have renal failure, and eventually all of this is going to catch up on him. He's not getting dialysis, right? Hemodialysis is basically a manual way of doing the kidney's job, right? So I wrote it here. Dialysis is a way, I'm going to put that word into, dialysis is a manual way to do the failed kidney's job. Without dialysis, the patient will present with renal failure. Creatinine and BUN would obviously be high. So, urea, nitrogen, creatinine, those two things, B and F, would be elevated because the kidney's not working well. The patient would have metabolic acidosis, right? Because uremia is the U of mud piles. And that metabolic acidosis is going to be because of the loss of bicarbonate. So the only thing that would decrease would be the bicarb. Answer choice A. Med acidosis, you have to remember mad hunger, right? Mud piles, you obviously have to remember from the acid-base physiology section. And the U is uremia. And then mad hunger is the thing related to the uremia. Metabolic acidosis, dyslipidemia, hyperkalemia, uremia, sodium water retention, growth retardation, developmental delay, erythropoietin failure, and renal osteodystrophy. Right, so all of that is a basic summary of things that happen with renal failure, which is obviously super high yield in every medical test. Okay. A 50-year-old man comes to the physician for follow-up treatment of progressive disabling osteoarthritis during the past 6 years. The physician has just learned of a promising experimental treatment for this condition. The company that produces the new drug is offering physicians $100 for each case referred for treatment. The physician believes that the patient is a good candidate for this drug. Which of the following best describes whether the physician should tell the patient that she will receive $100 for the referral? And the answer is obviously most definitely yes. You have to be very transparent. As a physician, always remember you need to be transparent, right? That also entails not lying, right? So if you made a mistake, you have to be transparent about it. Hey, I made a mistake. I gave you procedure X. Instead, you were supposed to get procedure Y. My bad. Do you risk getting sued? Do you risk getting in trouble? Sure you do. But you have to be transparent. You cannot hide things and you cannot lie about things. So yes, you would. And then you're between two things. Do you offer to share the money with the patient? Or yes, the patient may wish to consider the money's influence on the physician's recommendation. And think of yourself as the patient rather than the physician. You would want to know if your doctor is going to make extra money for prescribing a certain medication to you. Because you would care. You'd be like, all right, so are you prescribing the medication to me because you're about to get $100? Or are you prescribing it to me because you really think that that medication will help me? Right? That is the correct answer. D doesn't make sense for two reasons. Because one, this isn't always really necessary. Think about it. What if your patient is richer than you? Do they even care about sharing money? Not really. Second of all, this kind of incentivizes the patient to take the medication. This $100 referral is an incentive for the physician to give the medication to people, and it's not really that much of an incentive. As a doctor, you make a lot of money. It's not as much of an incentive as it is a thank you, right, by the pharmacy company to tell the doctor, hey, thanks a lot for giving out my medication to people. It's going to help them with their phase 4 of clinical trials, which is the post-marketing surveillance. So yes, you do tell the patient, and the patient gets to figure out whether or not they want to take that medication, or go do their research and see maybe you're just giving them the medication because you want to get the $100 referral for some reason. Biostats, right? So a study is conducted to assess the prevalence of hypertension in Caucasian people compared with African American people. So what happens in this question, make sure you get it, and then hopefully you never have to come back to this topic ever again. Just master it. It helps to master things while you're studying in such a way that you never need to revisit it again. So here, they're doing a study to check hypertension in white people, Caucasian people, compared to African people, African American. Right, so a total of 500 Caucasian participants, Group X, and 500 African American participants, Group Y, between the ages of 25 and 40 are enrolled. Blood pressure readings are taken from each participant 3 times over a period of 3 months. The prevalence of hypertension in group X is 10%, and the prevalence of group Y is 16%. Which of the following statistical tests is most appropriate to determine if this difference is statistically significant? Okay, so notice though, right, this question doesn't give you any blood pressure readings, right? They didn't give you, what were the blood pressure readings of each of these people, and what the mean was, right? What the average blood pressure was. The statistical breakdown, they didn't give you any of that. What they gave you is whether or not someone has hypertension, right? So you would just go use the chi-square test. The chi-square test is also known as the categorical data test, right? So like the way I wrote it here, the chi-square is used for categorical data, where you have two or more percentages or proportions of outcomes, but no means. Despite a numeric value of blood pressure being measured, patients are being categorized as either being hypertensive or normotensive. That's it, right? T is meant for 2, and that reminds you, let me put that in. T is meant for 2. And the meant is to remind you of mean. That's why I put it in caps, right? T is meant for 2 reminds you that t-test is for 2 means, while ANOVA, analysis of or variation, is for 3 or more means. Okay, the Pearson correlation shows you a positive or negative correlation between 2 variables, and multiple logistic regression analysis applies when there is a single dichotomous outcome and more than one independent variable. That was completely irrelevant to our question in general, but you definitely want to know about the ones that are in the book. Okay, the ones that are in the book, you definitely want to make sure that you don't have any trouble, understanding these things. The Pearson correlation coefficient and these common statistical tests. There are more other common statistical tests, and if you're ever doing a question where all 3 of these don't seem like they fit, the question stem, then go with the thing that you might not know. For example, this could have been another question where no other answer choice was making sense and you were just down to D. Then you would just pick D. Because if nothing else makes sense, right, then by elimination, D would probably be the correct answer choice. But for our question, chi-square test made the perfect sense. So now, this topic you should never need to study again. It's like a one-time thing. You master it, you never come back to it again, right? T-test for 2 means, ANOVA for more than 2 means, and chi-square for 2 or more categorical outcomes. No means. Not mean values. That's it. These 3 are most likely the only thing you'll have on your step 1. There's really never been a URL question or anything else that used the statistical data test that was other than one of these 3, so don't worry about it too much. And the correlation coefficient, or the Pearson coefficient, you can get an answer choice that just says Pearson coefficient without the word correlation, because the word correlation kind of gives away what the Pearson coefficient is about. It's a correlation of factors, right? How closely related are the 2 variables you're testing? So really easy topic, but if you don't remember any of it, then you won't get the question right. So just memorize it. It's a one-time study thing, really not something you need to come back to frequently. Shock. Okay, so 30-year-old man is brought to the emergency department 30 minutes after being stabbed in the abdomen during a robbery. His pulse is 130 per minute, respiration is at 28, mean arterial blood pressure is 50, and pulse pressure is 5 to 10. A diagnosis of rupture of the aorta is made. Which of the following is expected to occur as a compensatory response to this rupture? So he's obviously bleeding like crazy, so he must have hemorrhagic shock, right? Now, this link, I'm going to share it in the chat right here. This link was really nice, and derangedphysiology.com is actually a really good website for understanding any topic you might have difficulty getting. It might be on the website, it might not. It doesn't really have everything on this website, but it's a good website. Generally speaking, this patient has hemorrhage and will undergo hypovolemic shock. The hypovolemia causes baroreceptors to sense a drop of blood pressure, leading to an increased ADH release, right? So that makes the answer choice A wrong. Decreased ADH would be wrong, right? You would have increased ADH release. There will be an increase in sympathetic tone because you're in the fight or flight mode due to the bleeding, and that would cause vasoconstriction, so C is wrong. The heart rate will increase to maintain cardiac output despite the drop in preload, because cardiac output equals heart rate times stroke volume. So now that stroke volume is low because you have hemorrhage and you lost blood, heart rate must be high to maintain cardiac output. The kidneys will preserve urea and sodium to maintain volume, right? That's pre-renal azotemia. So that's answer choice B, which is also incorrect, right? I'm just knocking out all the other answer choices here. The decreased blood flow to the kidneys will activate RAS, causing more conservation of fluids. So the correct answer here was just F, increased serum angiotensin II concentration. Right? You would activate RAS because you have hemorrhage. Definitely want to make sure you understand all the shocks perfectly. Right? There's a very high chance that you're going to get a question on each one of them on step 1. Right? So hypovolemic is the one that has people with hemorrhage or dehydration or burns. Cardiogenic is the one where inside the heart you have some kind of problem leading to shock, right? So arrhythmia, acute MI, any of these. Or it can be an obstructive shock, which is right outside the heart, right? So extrinsic to the heart. Tamponade, pulmonary embolism, tension pneumothorax, any of these things. They both cause the same kind of presentation. And then distributive shock, which is different from all of these other ones. Distributive shock is due to sepsis, like septic shock, anaphylactic shock, right? This is the one that has warm skin because sepsis and anaphylaxis actually cause a lot of vasodilation, right? And treatment is actually to use IV pressors, right? You have to give them pressors because you see how this is happening. Blood pressure fell really, really hard. And the other is blood pressure went up. Now, but here blood pressure goes really low. Patient gets very hypotensive. And I have paragraphs up here and down here to help explain more of it. So definitely make sure you take a look at that, read it, understand all of them. The CNS injury one is also pretty critical. This is probably the least high yield of all these topics of shock, but I wouldn't be surprised if it was on your step 1. So definitely make sure you know neurogenic shock as well. Here, this one. Okay, yeah, this is hepatic encephalopathy. So 35-year-old man is admitted to the hospital because he has been vomiting blood. He has a 15-year history of alcohol dependence and biopsy-proven cirrhosis. So his liver has already gone to shit and he's an alcoholic. Examination shows ascites, prominent periumbilical veins, and hemorrhoids, all which are signs of portal hypertension. Over the next 7 days, his level of consciousness decreases and he develops a flapping tremor of the hands. And at this point, you should immediately be like, okay, yeah, that's due to hyperammonemia. The pathogenesis of the neurologic symptom is most likely directly related to which of the following? Right, so the way I read this question was a very active way of reading it. Right? This is kind of what I train students to do when I work with them personally and do questions. Right? Read questions very actively, which means that as you're listening to the patient's scenario being described to you, you want to, come up with your own thoughts about it, not just keep reading and reading, because then at some point you might just get drowsy and read a sentence and not even absorb what is said. Okay? But if you're actively reading it and you're coming up with your own deductions about each sentence, then oftentimes what happens is whatever you thought of shows up in the next sentence you read, right? Which is reassuring. It feels good, and then you feel like you're on the right track. The pathogenesis of the neurologic symptom. So they're basically talking about the flapping tremor and the consciousness, which is due to hyperammonemia, as we just said. And the only answer choice that had anything to do with hyperammonemia or high levels of nitrogenous products was just A, right? Absorption of nitrogenous products from the GIT. Now, how does that happen? So this is another thing you definitely want to make sure you learn and know the first time you look at it, which is, it could be right now or it could be some other time and you might already know this. But how does his scenario of a GI bleeding and portal hypertension, alcoholism, liver cirrhosis, how does that lead to hyperammonemia? This patient is evidently alcoholic with hepatic cirrhosis. The patient is exhibiting signs of hepatic encephalopathy. Liver cirrhosis causes portosystemic shunts that lead to a decrease in ammonia metabolism. Remember this. Now, this is the thing you really need to know. This is the whole pathophysiology of this. Ammonia is produced by the GIT as a result of catabolism of glutamine, and GI bleeding causes increased nitrogen delivery to the gut in the form of hemoglobin, which is then converted into ammonia and absorbed into the bloodstream. The ammonia enters the liver and is detoxified to urea. However, in our guy, the liver isn't working. So in liver failure, portosystemic shunts impair this detoxification. The only way to get rid of all the ammonia now is to combine it with alpha-ketoglutarate from TCA and combine it with glutamate instead of making GABA, all of which helps you make glutamine ultimately, right? Patients are now unable to do the TCA or have GABA activity. The lack of TCA is causing him to be really weak and lowering his level of consciousness, and the lack of GABA is causing a tremor because GABA is inhibitory. The answer choice E, thrombosis of hepatic veins, which was another choice that a lot of people chose. Thrombosis of hepatic veins is Budd-Chiari syndrome, which is related to a hypercoagulable state or polycythemia vera or postpartum and hepatocellular carcinoma. This patient may have hepatocellular carcinoma and might eventually have Budd-Chiari syndrome, but even if this patient actively has Budd-Chiari syndrome right now, it doesn't explain his neurologic symptoms. Okay, so his neurologic symptoms are due to hyperammonemia, which is answer choice A, absorption of nitrogenous products. So this is discussed in the book in multiple places. Page 82 first mentions hyperammonemia in biochem. So right after the urea cycle, they talk to you about hyperammonemia. And it can be acquired from liver disease or it could be hereditary due to urea cycle enzyme deficiencies. This is why I always tell people to go back to first aid for every question they do, because you create a mental map of what you saw on the same page. Right? And when you come to this page, you see two things. You see the whole urea cycle thing, and then you see hyperammonemia. Right? And in between is a discussion of transport of ammonia by alanine, right? And how it starts from here. You have amino acids and alpha keto acids are being formed. All of this became glutamate, which then became alanine, went through the Cahill cycle, and it was brought into the liver. In the liver, you regenerate it into glutamate and make urea to excrete it, right? And this is if your liver is working. If your liver is not working, you won't be able to do that. The Cori cycle just cycles between glucose and lactate. That's it, right? With pyruvate in the middle. So it's a very important section, this middle area. You definitely want to make sure you know it. And the reason it's important is because this is directly related to your liver enzymes. And hyperammonemia, this little diagram here pretty much tells you everything that's happening, right? You combine ammonia with alpha-ketoglutarate because the main goal is to get rid of all your ammonia. So combine ammonia with alpha-ketoglutarate, you make glutamate. Combine ammonia with glutamate, and you make glutamine. However, you end up running out of glutamate and running out of alpha-ketoglutarate, which is really bad. Okay, and you end up having very high amounts of glutamine, which is actually a pretty high yield answer choice, right? UWorld had a question where glutamine was the answer, and many other places where you read about hyperammonemia, glutamine is a big topic of discussion. Even in this little picture here, you can see from UWorld, they describe how in the blood, you see ammonia right here, right? It's being taken up. You're accumulating a lot of glutamine here, right? Because of glutamine synthase, then you send it over here, right? This is all the effects of hyperammonemia on the glutamate-glutamine cycle, right? And ultimately, what you end up doing is you accumulate too much glutamine, right? And you run out of glutamate, which you need. Now, where else do they talk about it? They then later talk about it again on page 385, right after liver disease, right? Alcoholic liver disease, and then non-alcoholic fatty liver disease, and then hepatic encephalopathy. And you can see here, cirrhosis leads to portosystemic shunts, which decreases ammonia metabolism. That leads to neuropsychiatric dysfunction. And treatment involves using lactulose to make more ammonium, or rifaximin or neomycin to kill the bacteria that would help you, make more ammonia, because you don't want to make more ammonia. So very important to make sure you understand hyperammonemia, very high yield topic, obviously something that can occur in your actual practice as well. Okay, 23-year-old woman develops multiple red papulovesicular lesions following exposure to poison ivy. Which of the following is the most likely mechanism of underlying the development of these lesions? So they're talking about poison ivy, right? And they want to know about what kind of hypersensitivity that would be. So if you remember it, then you would be fine, because poison ivy causes contact. It's under the list of things that cause contact dermatitis, which is a type 4 hypersensitivity. So type 4, you remember, has nothing to do with antibodies or antigens or complement. So you would knock out any answer choice about that, like answer choice C, for example. Antigen-antibody complexes, right? This would be wrong. That would have nothing to do with it. Type 4 is a delayed type of hypersensitivity, which occurs due to T cells. And the only answer choice that mentions T cells is answer choice E. Right, the T cells right here. Processing of antigens by Langerhans cells, leading to activation of CD4 positive T cells. Right, and they really try to confuse you and intimidate you, because now, depending on your mastery of immunology, you might be like, is it CD4 T cells or not? What the hell are Langerhans cells? And if you don't know those things, then you might not be so inclined to pick E, because there's, imagine if Langerhans cells was not correct. Then even though answer choice E talks about T cells, E would be the wrong answer choice. So if you don't know about Langerhans cells, if you don't know whether it's supposed to be CD4 or CD8 T cells, you will be pretty confused. But keep in mind that though CD8 are usually for viral infections, right? CD4 T helper cells, CD8 versus cytotoxic cells, completely different things, and they're used for two different issues. So this patient just has poison ivy issues, which triggers a type 4 hypersensitivity mediated by T cells. Poison ivy, nickel, and many other things cause contact dermatitis. Graft versus host disease is also a type 4 response. And your PPD, Candida skin test, those guys are also a type 4 delayed hypersensitivity, right? PPD for TB infection, Candida skin test for T cell immune function, all of this. Right, direct cell. So here you can see there's two. They listed out both things, right? There's either going to be a CD8 positive cytotoxic T cell killing targeted cells, or an inflammatory reaction for CD4 positive T cells recognizing an antigen. Our patient had the antigen thing from poison ivy. The CD8 positive thing would be for killing cells, like maybe in the PPD thing, right, where you can actually kill things. You don't really kill antigens, you kind of destroy them, and it causes inflammation. Over here is a little paragraph talking much more about the whole poison ivy thing. So, of course, if you're interested, feel free to pause the video and check it out. I think I'll put that into here too, actually. Because, in case you're new to the channel, I do sell the PDF that I'm using right now to describe, the explanations. And then I also sell the other PDF, the first aid, that's annotated. So I like having everything in both places so that people who buy stuff can access it. Alright, perfect, right? So that's your information about poison ivy. Alright, let's go to the next thing now. So we're into block 4 now. Okay, that's good. 21-year-old man is brought to the emergency department 1 hour after the acute onset of left-sided chest pains and shortness of breath. The symptoms began while he was playing basketball with friends. He's 5 feet 10 and weighs 138 pounds. BMI is 20. Pulse is 120 per minute, which is high. Respiration is at 30. Blood pressure is fine. Breath sounds are decreased on the left. So something's wrong with the left lung. There's hyperresonance to percussion of the left hemithorax, which means that left lung is just full of air. A chest x-ray shows a sharp line adjacent to a radiolucent region without lung markings on the left side, which means that lung has collapsed. Which of the following is the strongest predisposing factor for this patient's condition? So this is just about a pneumothorax, and what you needed to remember is what is the most likely kind of patient that can present with pneumothorax. Now, there's a lot written here because I wanted to talk about another concept, which is conditional probability, another way to tackle questions, right? This conditional probability concept applies to many questions, not just the one we're looking at right now. So this patient clearly has a spontaneous pneumothorax as evident from the hyperresonance and decreased breath sounds. It cannot be A, right? Collision with another player. That is very unlikely. Think of how many basketball players, and basketball players, because of answer choice E, collide with each other, right? So many. Football players collide with each other all the time. Basketball players collide with each other all the time. And you almost never hear about any of them colliding in such a way that you ended up having a pneumothorax, right? And there's a reason for that, because all of these players are really big and strong people, which leads you to the answer that the answer is C, gender and body habitus. If you're not big and strong, then you might actually collide with someone and end up having a spontaneous pneumothorax. You have to think about this using conditional probability. Another way to ask this question, this type of question, is like this. I show you a patient with spontaneous pneumothorax. Which other thing is most likely to be true about that person? Or you could phrase it in any of these other ways. Given a condition, like spontaneous pneumothorax, what other finding is most likely to be the case? Given a pool of people with spontaneous pneumothorax, what other thing is most likely to be true about majority of them? Right? These are all the same question. In other words, of all the people who end up with spontaneous pneumothorax, the most common other thing about them is that they are male and thin. And this is talked about in first aid as well. This is talked about by anyone you could think of who might have spoken to you about spontaneous pneumothorax, whether it be Kaplan, USOMA RX videos, DIT, whatever you watch. So if I gave you a bucket of spontaneous pneumothorax patients and you reached your hand in there and pulled one out randomly, what scenario would be more common? In your hand, you have in one hand, you have a smoker, or in your other hand, you have a thin male, which one is most likely? It's going to be the latter one, a thin male, not someone who smokes. And that's also an answer choice. D, history of tobacco use. So they put a bunch of answer choices here that can, realistically, can possibly cause spontaneous pneumothorax, but probability-wise, the most likely thing is gender and body habitus, right? Now down here is another conceptual thing just for training purposes, right? Off-topic example for conditional probability for study purposes. So imagine there's a town of 1,000 men, and before I read the rest of it, actually, I want you to think of this as one of those really long questions you often see on step one, right? Long questions like this one, or even longer. What they do is they often tell you something in the beginning that was very relevant. They'll tell you something in the very last sentence that was also very relevant. And of course, physical exam and labs are relevant, but they also tell you a couple things in between here and there that are very irrelevant, but they can throw you off. So that's kind of something that's going to happen here too. There's a town of 1,000 men. 900 of them work as lawyers. The other 100 are engineers. Tom is from this town. He rides his bike to work. In his free time, he likes solving math puzzles. He also built his own computer. What is Tom's occupation most likely to be? The most likely thing that he probably is a lawyer, right? He's most likely a lawyer. Why? Because 900 of them are lawyers, only 100 engineers. So if I gave you a random guy named Tom, he's most likely also a lawyer. Just because he built his own computer, likes solving math puzzles, and rides his bike to work, none of these things really confirm whether or not he's an engineer, right? Don't let assumptions distract you from the overwhelming force of sheer probability. Given that Tom is from this town, his most likely occupation from the available data is that he's a lawyer. Okay. Now, unless something very crude was given, that's obviously a sign of someone being an engineer, there's no reason to pick engineer as an answer choice here, right? Anyone can build their own computer. I've built my own computer once. It's really easy to do that. You can learn that from anywhere online. You can buy all the parts. It's a lot cheaper than buying your own fully built computer. And when you buy a fully built computer, it's usually not as good specification-wise than building your own. You can buy cheap parts when they're on sale. All kinds of sales happen all the time. You get your own hard drive, you get your own CPU, all of that, combine it, put it into the shell, you have a computer. Anyone can do it. So you don't need to be an engineer to build your own computer. I am going to be a doctor, and I love math. I was a math major. Right? So you can see how none of these things in these two sentences here, the liking math and building your own computer, confirm that he's an engineer. So just work off of the probability thing. Probability is he's a lawyer. Conditional probability is a very useful tool for tackling many types of questions in medicine, or any topic actually. All right, moving on. 13-year-old girl is brought to the emergency department 15 minutes after the sudden onset of shortness of breath. She has a 9-year history of episodes of soft tissue swelling, particularly involving her face and extremities, but without urticaria or erythema. Some of these episodes have been accompanied by acute abdominal pain with diarrhea. She has no history of severe or frequent infections. Temperature is 98.6, pulse is 81, respiration is at 20, and labored with marked stridor. Blood pressure is low. Physical exam shows marked facial edema. Treatment with danazol and stanozol resolve her symptoms. Most people should know what danazol is. You might have never heard of stanozolol. Stanozolol is not a beta blocker, that's for sure, but it does sound like one. But you do, if you've never heard of either of these medications, you definitely want to go ahead and Google them. They're both used for exactly what this patient is going through. The most likely cause of her condition is a deficiency of which one of the following substances, and by asking the question like that, they actually ended up making the question very easy. This is clearly hereditary angioedema, and hereditary angioedema is a lack of C1 esterase inhibitor. So this was a very easy question. High bradykinin causes the cough and shortness of breath, and you will make sure you know that there's no urticaria, which they told you. Danazol and stanozolol are both medications that can help with hereditary angioedema. Type 1 and 2, there's two different types, there are many types actually, are caused by a mutation in SERPING1 gene that makes the C1 inhibitor protein. Other people can just have a random mutation as well where they stop making it. Either way, C1 esterase inhibitor can occur to anyone, and the main thing is you have to remember not to give them ACE inhibitors. Because ACE inhibitors already increase bradykinin and can cause cough in people. So you would work with ARBs for these patients and not ACE inhibitors where necessary. 50-year-old man with chronic gastritis is diagnosed with the marginal zone lymphoma of the stomach. Now, if marginal zone lymphoma did not ring a bell for you, then that's probably because you read about it very inactively, right? There's passive reading and there's active reading. If you read about marginal zone lymphoma and hem-onc and completely can't recall one thing about it, then you didn't read it actively. And we're going to take a look at it right now. Which of the following organisms is most likely associated with the development of this lymphoma? So he has chronic gastritis and he got marginal zone lymphoma in the stomach. The only organism that's most likely possible to cause this in the stomach would have to be answer choice D, Helicobacter pylori. Why is that most likely? Because almost everyone, heck, everyone has H. pylori. Right? Everyone has it living in them somewhere, and it can definitely access more stomach tissue if you have chronic gastritis. First, keep in mind that the patient has chronic gastritis. The mucosal atrophy leads to hypochlorhydria, which causes hypergastrinemia. The hypergastrinemia increases the risk of intestinal metaplasia, such as leading to gastric cancer. H. pylori causes malt lymphoma in such cases. Marginal zone lymphoma is related to chronic gastritis. So let's go take a look at both things. Chronic gastritis, so that's GIT. Right, so you have acute versus chronic. The acute gastritis can be one of three things. It could be because of NSAID use, where now you don't have any protective prostaglandin production anymore. It could be due to a burn, which is a curling ulcer. So that's why I have this hair color here. If you have a burn, you become hypovolemic, and the hypovolemia leads to mucosal ischemia. You lost blood. It could also be due to a brain injury. That's called the Cushing ulcer. So you cushion the brain. Cushing ulcers lead to increased vagal stimulation, and vagal overactivity causes too much acetylcholine, which leads to high acidity. All right. Chronic gastritis can be type A, B, or C. Type A is autoimmune, and that affects the body, right? A before B. Always remember A before B. So type A is autoimmune. That starts with A. Body starts with B. So autoimmune body. Type B is bacterial, right? Bacterial goes to the antrum. Right, so bacterial stuff affects the pyloric antrum area right here. Type C is chronic NSAID use. Right, that one they don't talk about here because they already told you the acute version of it. Now, H. pylori, you can see right here, is the most common, and it increases the risk of peptic ulcer disease, which can cause GI bleeds, and it can increase the risk of malt lymphoma. But now you're thinking like, all right, that's malt lymphoma, mucosal, whatever ALT stands for, I completely forgot. Let me check that real quick. I think it was mucosa associated lymphatic tissue. Yeah, mucosa associated lymphoid tissue. Okay, so what does that have to do with marginal zone lymphoma? So now we could take a look at marginal zone lymphoma and hem-onc. So here is marginal zone lymphoma. It's one of the neoplasms of B cells, discussed with all the other guys that you studied really hard: Burkitt, follicular, mantle cell, diffuse, primary central. Marginal zone lymphoma is the one that has the T1118 translocation, right? Chromosome 11 with the cyclin D1 and chromosome 18 with the BCL2. BCL2 is conservative. That's what the C stands for. BCL is the opposite of BAX. These genes are discussed in the pathology section. BAX, backs and back, all the A guys, the A in the middle, are apoptotic, whereas the BC guys, the BCs are conservative. They do not cause apoptosis at all, leading to cancer, right? Your cell becomes immune. Cyclin D1 is part of the whole cycle of replication. So here you can see marginal zone lymphoma is associated with chronic inflammation, which includes chronic gastritis. Right? Marginal zone lymphoma is a malt lymphoma. So that connection was very important to know, but it's, very rarely discussed, very uncommonly, seen in questions. So NBME definitely did a good job picking on it, and it can definitely be on your step 1 too. I also listed out what the other viruses and bugs here are kind of related to. A 52-year-old man with stable angina pectoris begins treatment with a medication that decreases cardiac preload and increases coronary artery blood flow. This patient is at greatest risk for which of the following adverse effects of this medication? So, this is cardiovascular medications. He took a medication that increases coronary artery blood flow, which as soon as you read just this part, forget the decreased cardiac preload, that might be intimidating to you. But if it increases coronary artery blood flow, the only way you could do that is through vasodilation. So now you want to stop and think of all the things that can cause vasodilation. You have your calcium channel blockers, you have nitrates, right? And then you look at all your acid choices. And if you think about it, this was a very straightforward, easy question about nitrates. Nitrates are known for causing headache. Right? Monday disease is part of that. Let's go look at it in the book real quick. So calcium channel blockers, these are used for hypertension, right? And this patient, he has stable angina pectoris, so you wouldn't necessarily think of calcium channel blocker as an answer choice. But, they are relevant for vasodilation, sure. But our guy is being treated with a nitrate, right, which is used for angina, acute coronary syndrome, pulmonary edema. Nitrates cause reflex tachycardia, so you treat that with a beta blocker. Hypotension, because of the vasodilation. Flushing, and headache, right? Headache is actually the number one side effect, the most common side effect of using nitrate therapy, right? Almost everyone who takes nitrates will get a headache. In fact, Monday disease is also a part of that. People who end up having tolerance of the vasodilating action over the work week and then loss of tolerance over the weekend will present with headache upon re-exposure. Okay, so this is just a question about nitrates causing headache. That's it. Nothing else. All these other side effects are for completely different medications. Like digoxin would be related to visual disturbance, right? Nausea and stuff, other medications. On another note, another cardio medication that has interesting side effects is adenosine. Remember that adenosine can cause flushing, chest pain, bronchospasm, and a sense of doom. And adenosine is a really interesting medication that is also pretty high yield because of how weird it is, I guess. The last few things they talk about in cardio pharm, right? Adenosine and ivabradine. Ivabradine even had a question in UWorld, and they had a graph for it. They had an image for it, right? But adenosine, I have this picture for right here. You can see it has two different receptors it works with. It works with an A1 and A2 receptor. The A1 receptor is in SA and AV nodes, where it works with GI and decreases cyclic AMP to reduce chronotropy and dromotropy. But adenosine also works on vascular smooth muscle using the A2 receptor. These are not alpha 1 or alpha 2. These are A1 and A2. The A2 receptor actually works with GS to increase cyclic AMP and cause relaxation. Right, so that's also a medication that can cause vasodilation. It's actually used for coronary stress testing. Okay, so because it has a very small, short acting. There you go. Yeah, small action, duration of action. Yeah, small duration of action. All right, but generally speaking, these medications, are just mainly tested on exams, not really a big deal in real life use. Now, questions I've seen on adenosine usually ask about the flushing part. Right? The flushing part is a pretty big deal here. So if you're thinking of any cardiac medication and the question is asking about why the patient has flushing, or what kind of side effect would you see in the patient, and then flushing is an answer choice, think of adenosine and then see if this fits. Right? So this increases potassium exit from cells. Potassium leaving is a sign of repolarization, so it causes hyperpolarization, decreasing the AV node conduction. Drug of choice for diagnosing or terminating certain forms of SVTs, supraventricular tachycardia. Effects are blunted by theophylline or caffeine because these guys also utilize similar or the same receptors for the most part. Adverse effects are flushing, chest pain, and some weird sense of impending doom, which is really interesting. Okay, so that's just another off-topic discussion relevant to cardio pharm. This is a nice question to discuss something that a lot of people tend to mess up. So this is all about parathyroid hormone. 62-year-old man comes to the physician for a follow-up exam. He has hypertensive nephropathy and chronic renal insufficiency, right? And that's very important information. Current medications include clonidine and calcium acetate. His blood pressure is 145/92, so it's high. Lab studies show serum creatinine that's also really high because he does have renal insufficiency, so it makes sense. And a serum calcium of 7.8, which is low. Which of the following additional sets of concentrations is most likely in this patient? What's most likely in this patient? Okay, so you look at it, they have phosphorus, PTH, and calcitriol. All right, so they already showed you, right? Let me just make sure actually. Yeah, they already showed you that his calcium level that they're giving is pretty low, right? 7.8. So you can, when they talk about calcitriol, there's no reason for that to be elevated. So you can knock out the two answer choices where it's high. Right, so now you're between A, C, and E. Now, this patient has renal failure. Calcium will be low and the patient will make PTH to fix the low calcium, right? Since the kidney is not working though, PTH will be ineffective, so phosphorus will still be high. And this is where people mess up, right? Because everyone goes like, okay, calcium is low, so you're making PTH. PTH is phosphate trashing hormone, it throws away phosphate, and everyone ends up picking answer choices like this one here, E. Right? Everyone goes with E. But you have to remember that yes, calcium is low. Yes, you're going to make PTH, but PTH will not work because the kidney is not functioning. So phosphorus will still be high, and A is the correct answer. Right? A lot of people, forget to make that reasoning there. Don't be that way by the time you get to step one. Right? Understand that you are able to make PTH because your parathyroid gland is working. If it wasn't working, then yeah, you would have low calcium and you would have low PTH, right? So PTH is going to be made because your parathyroid gland is working, but phosphorus will be high. Even though you're making phosphate trashing hormone, you will not be trashing any phosphate because you have chronic renal insufficiency, right? PTH will be ineffective. If PTH was working, your calcium would also be high again. So, you got to think about everything there. So A was the correct answer here. This was just an intimidating question for anyone who feels a little weak at these topics. This is the second question on pharmacokinetics in this NBME. A 56-year-old man develops brief episodes of ventricular tachycardia 14 hours after having an acute MI. The arrhythmia will be treated with a loading dose of lidocaine followed by a continuous infusion of the same drug over the next 24 hours at a rate to maintain therapeutic steady state drug concentration in plasma. To maintain a steady state plasma concentration of lidocaine, the appropriate rate of infusion of the drug is best determined by which of the following calculations. So they basically want you to figure out the maintenance dose, right? Now, how do you calculate the maintenance dose? That's all this question is asking you. If you don't remember, right, then of course you're a little fucked. It would help to remember. But if you don't remember, then hopefully you have some good knowledge of pharmacokinetics and you can actually come down to picking the answer. The first thing you notice is the first half of answer choices are related to CL, which is clearance. The latter half of answer choices are related to volume of distribution. And you need to remember where was volume of distribution important and where was clearance important. Now, the loading dose is actually related to volume of distribution, right? Because when you're loading a patient up, you have to see how much distribution you have to load, right? That's kind of how you want to think about it. If you're loading a patient with medication and the medication has a very high volume of distribution, you have to load them with more medication. So that means that since we're talking about maintenance dose, it's definitely not E, F, G, or H. So you cut out half your answer choices. Now you're left with clearance, right? And clearance is relevant for the maintenance dose because you're maintaining the amount of medication in the patient's body, which is relevant to how much is being cleared. The rest of the answer choices, from here, A through D, are only now different based off of half-life or CSS. What will be the other thing you need? Well, you definitely need to know your steady state drug concentration, and you're not going to be dividing the two things, so it's A. Okay, and this is definitely deducible. It is deducible if you know what each of these variables means, right? And what the concept of maintenance dose and loading dose is. You don't want to sit there and memorize the equations. That's what you don't want to do. These equations are not meant to be memorized. They're meant to be understood. Maintenance dose is your steady state concentration times clearance times the tau, the number of times you gave the medication, divided by bioavailability. All right. Um, and loading dose is your steady state concentration times volume of distribution. Right, so very important to make sure that, let's take a look at it in the book too, that you get that down. Pharmacokinetics is all just one page. It's not multiple pages, it's just one page. And this last thing is not even that mathematical, but it's also very important to understand. You need to know the difference, especially between additive versus synergistic. You need to know the difference between them. But you see dosage calculations here. So loading dose, right? CP, target plasma concentration, times volume of distribution. Right? You multiply the two. The only division is by bioavailability, which is why you never divide, because bioavailability is usually just 1. Maintenance dose has to do with clearance and tau, dosage interval, number of times you would give the medication. And tau is also just 1 if you're giving it continuously. And this is also relevant for patients who have renal or liver disease. The loading dose is never changed, because you can see the loading dose has nothing to do with clearance, right? But the maintenance dose does change, because in renal or liver disease, clearance might be lower, right? So if you're not clearing enough, you might have to give higher amounts of the medication to reach the same steady state. Okay, so that's it for that topic. 159. Okay, child development. This wasn't so bad actually. This type of question can be a little harder than the specific one here, but NBME 22 is pretty doable. So 3-month-old girl is brought to the physician by her mother for a well child exam. Her mother says that the infant can lift her head while lying prone. So that's good. The patient is eating well and recently started sleeping about 6 uninterrupted hours through the night, which is also pretty good. The mother adds that the baby does not smile in response to human faces yet. That's not good. And has not started to coo or gurgle with attention. That's also not good. The patient is at the 25th percentile for length and weight and 10th percentile for head circumference, which, earlier we were talking about these percentiles, right? And I was telling you how the percentiles are pretty irrelevant unless they're under 40. Well, here, they're below 30, and they are something of some minor concern. It is, of course, only a 3-month-old girl, so things might change very rapidly, very suddenly, but definitely of concern. Physical exam shows no other abnormalities. Which of the following best describes this infant's development? Well, for one thing, I definitely know this child's development is not normal, right? So I'm going to cross out A. Now, motor development was good because the baby was able to lift her head. So, I can cancel out E, F, G, and H. And then social and verbal were not good, right? Because the baby doesn't have the social smile, does not smile in response to human faces, and the baby does not coo or gurgle when given attention. So you just go with D. Normal, delayed, delayed. That's it. So this was a pretty easy version of this kind of question. This kind of question can present slightly more hard, especially if the baby's a little older than 3 months, because then the 6 and 9 month phases, it really helps if you've been around a baby. You get to see more of it. But the 6 or 9 month phases have other things happen. Right? So you definitely want to spend a little bit of time getting this. If you can be around a baby, you can definitely get to see more of this actively, right? And then the later ones, toddler and preschool, these aren't so bad. These are actually pretty easy to understand, and I've seen some UWorld questions about it too. Keep in mind that language is the most commonly delayed milestone, with a prevalence of up to 15% at age 2. Children suspicious of language disorders should undergo further assessment, such as a hearing exam and a speech and language evaluation. And so the verbal part is usually the hardest part and the most sensitive part in a developing child. Last question for this video. So a 29-year-old woman has an inflammatory disease involving her joints, kidneys, serosal surfaces, anterior chamber of the eye, and choroid plexus. Which of the following is the most likely mechanism of this disorder? Right? So as you were reading this, inflammatory disease, joints, kidneys, serosal surfaces, it's already starting to sound a lot like lupus, right? Anterior chamber of the eye, so that's like uveitis, and choroid plexus. These two are really just here to throw you off and confuse you. Don't let that happen. Already, it looked like lupus, so understand that it most likely is lupus. It doesn't really sound like anything else, and your main instinct was probably correct. So you look at all your answer choices, and D immediately makes sense. Immune complex mediated cytotoxicity, which is exactly what lupus is. That's also exactly what lupus nephritis is. Okay, it's lupus. All the symptoms listed are classic, especially the serositis. Anterior chamber of the eye is uveitis. Choroid plexus leads to cerebritis, which is not that commonly tested. For a great overview, check out this video. So I'm going to post it here too. This is from Online MedEd. You just have to make a free account to check it out. So if you want to check it out, you can. But generally speaking, it's just all lupus. It's very easy. Lupus is mainly a type 3 hypersensitivity, which is why D makes sense. Some of it is also type 2. Okay, there are some antigen antibody issues. Later you get complement issues as well, and it all causes a lot of inflammation. So obviously lupus is very high yield, and this was pretty easy to figure out here. All right, so we'll stop here, and then in the next video we'll continue on the rest of block 4. All right, thank you very much for joining. Catch you guys later on.